Alright guys, so in this video we talk about leukemia, and this is the first of the leukemia in the RBC series. And so the take-home point of this one is to see if you're able at the end of this to tell the story of how the cell develops from that stem cell all the way down past the blast cells into the more mature cells. And then when there's a problem in this, is like, well, if it gets stuck here, it becomes this, stuck here, it becomes that, and all the little details that kind of go with it. But I think if you understand the concept behind it, because we stress this all the time, the step one is a test of concepts. You strictly cannot memorize your way through this exam. You got to understand the concept behind it, and that's what we're trying to accomplish here. So, hope you like the video. All right, guys. So this question reads: a 39-year-old has fever and petechiae. Her lab findings are as follows: hemoglobin's 9, leukocyte counts 5,000, neutrophils 12, lymphocytes 20, blast cells 70. Platelets are 20,000, low, blast or elevated, low, low. A peripheral blood smear shows hour rods. Okay, so of course you're jumping all over hour rods. I mean, it's just kind of one of those classic step ones. Hour rods you associate, obviously, with a certain leukemia. Which of the following is most associated with the patient's condition? And of course, I didn't give you that leukemia. You had to go one extra step further. But the moral of this, and here's where you really have to, if you understand the concept behind this, of where this thing develops from, you can basically understand these labs. Even if they didn't give you this, you could narrow it down just based on these labs. Here's how it works. You have this stem cell, the CD34, and all this is straight out of the basically the step 1 book. And now you have a choice to either go into the myeloid, the stem cell is going to go the myeloid direction, or it's going to go to the lymphoid, okay? So it's either a lymphoid stem cell or a myeloid stem cell, meaning it's going to differentiate into something. So if it becomes a myeloid, it's going to have these options, okay? It's going to have these options. It can become an erythroblast, okay? It can become a megakaryoblast. It can become a monoblast, or it can become a myeloblast. All right? Obviously, you notice the last of it is blast, blast, blast. Over here, this lymphoid stem cell, it can become one of two things. It's basically going to become a T lymphoblast or a B lymphoblast. And blast cells are typically a little bit larger, but you notice the blast cells are what happens first. And before I really drive that point home, look what these things develop into. The erythroblast becomes the erythrocyte, right? Red blood cell. The megakaryoblast becomes the megakaryocyte, and this is the guy that's going to give us the platelets. Okay? The monoblast makes the monocyte. Okay, kind of boring. Now, this myeloblast, they can become one of three things. Okay? They can be one of three things. They can become the neutrophil. They can become the basophil, or they can become the eosinophil. All right? Now, these things start to, you're familiar with these kind of terms, right? These are on our CBC and stuff like that, because they're measuring the mature versions of what these things develop into. These are the ones that should be hanging around in bigger numbers. Now, the T lymphoblast becomes they call it like a naive T cell, and then it eventually becomes the T lymphocyte, CD8, CD4, okay? And bear with me, it'll all make sense here in just a second. The B lymphocyte turns into the naive B cell, and the B lymphoblast becomes the B lymphocyte, and we like to think plasma cell, okay? Plasma cell. Now think about this. This all came from the CD34, right? This hemopoietic CD34 stem cell became a myeloid stem cell or a lymphoid stem cell, and then they went to the blast, and then they matured, okay? So let's just think about this. If we drew a line, you would say that these guys above that line are more immature, okay? Or as we could say, acute, okay? Everything below this line, we're going to say is more mature, and we're just going to say chronic, okay? So again, above the line, acute, below the line, chronic. And that's just based on maturity, right? Time and maturity. So here's where all this leukemia stuff comes into play. If I'm a myeloid cell and I get stuck in the immature area, right? That means I'm an acute myeloid leukemia, also known as AML. Okay, that's easy enough. If I'm allowed to mature, I become and then I have a problem with these guys, okay? And this essentially says it gets stuck here, and then that's where the problem's at. And it's an acute myeloid leukemia, if this. So what kind of cells would I see? I should see blast cells. I should see a ton of blast cells with this. Now, does that mean anything? Well, as it matures, normally it should mature down here, and then if I have a problem with these cells, where there's abnormal numbers or they don't work, then this is called a chronic myeloid leukemia. Okay? You see how these things are, it's obviously they're just derived on where they fall. Over here, if they're immature, well, they're blast cells, but they're lymphoid blast cells. So that's acute lymphoblastic leukemia, also known as ALL. And then, of course, the last one, chronic lymphocytic leukemia, also known as CLL. Okay? So there you go. Everything derives from that. But if you can tell that story, you can easily say, oh, I know AML, I know CML, I know this is the ALL, and then CLL side. Now, you just have to know for step one the basics of what goes with each one of these, and then you can easily find this. So if we were to start with ALL, and that's the one that most people, they're kind of familiar with ALL, just because it's the easiest one, right? What's the age? Kids, okay? Associated with what? Down's syndrome, okay? And what would we say? It can become an acute T lymphoblast or B lymphoblast. And then, well, how do I even know that it's going to be a lymphoid cell here, okay? Or lymphoblast? Well, the lymphoblast have TDT, okay? Have TDT in the nucleus, okay? It's very important. And TDT in the nucleus. That is very unique to the lymphoblast, okay? Lymphoid blast. The lymphoid blast is right here. I know that it's a lymphoblast if it's TDT positive in the nucleus. But then your next question should be, well, how do I know it's a T or a B? Okay, how do I know whether it's a T or a B? Well, they got these markers, okay? The pre-B are CD19, CD10, okay? So for a pre-B, I should have put this on the other side. So this is going to be the B lymphoblast side. So for the pre-B, the markers are going to be, the marker is going to be TDT positive in the nucleus, but you're going to see CD19 and CD10 positive. For the pre-T, it's going to be CD1, CD2, and CD5. Okay? So again, how do I know? Well, they're lymphoblasts. How do I know they're lymphoblasts? Because they were TDT positive. That's going to be probably a test question somewhere in there. How do I know whether they were pre-B or T? Well, it's because I had these markers on there, and that's usually where it falls. Now there's also some translocations for the B's, but now we're kind of getting deep into the weeds a little bit, okay? And I think 1221 translocation in kids. I want to say it was previously with Ewing's. I have to kind of confirm that. But anyways, for our purposes right now, I want you to know just these facts. Kids, Downs, TDT positive, and I differentiate between these markers. Now, if it was acute myelogenous leukemia, what should I see? I should see a ton of blast cells, right? A ton of blast cells, more than usual. So for AML, what am I going to see? Well, the key with this one is you're going to be instead of it being TD positive, it's myeloperoxidase, okay, positive in the cytoplasm. Okay? Remember, TDT was positive in the nucleus. For AML, it's positive myeloperoxidase in the cytoplasm. Okay? Associated with a translocation, 1517. Okay? Associated with 1517. Now, what I should kind of clarify is that this AML or acute myeloleukemia, it could be any of these guys, right? And so if it's acute, if I have a problem with the myeloblast, okay, acute myeloblast, they call it M3. Acute monoblastic, I mean, if I have issues with this guy, it affects the gums. And it's the megakaryote, this is the one that's associated, this is also associated with Downs. So don't be fooled. I remember one time I wrote a question and I was going after this guy with Downs, but they pointed out to me that also the megakaryoblast is also associated with Downs. And then the erythroblast that this guy is, but this is, as they say, pretty rare. The one that they're going to test on is going to be this myeloblast, the M3. Okay, that's the one that has the translocation of 1517. That's the one that's associated with the hour rods. Okay, that's the one associated with the hour rods. And this 1517 translocation, this is the one that has the retinoic acid receptor on chromosome 17. So that blocks the maturation. So this is the one where they give you the all-trans retinoic acid. So why? Why would you want to give the all-trans retinoic acid? What's the principle behind it? It's so it can mature. So this blast cell can mature into what it should be. Okay? But for your purposes right now, you need to know AML. Oh, that's easy. I should see a ton of blast cells. Well, what type of blast cells? Well, either erythro, megakaryote, mono, or myelo. What's the one they test on? Myelo. Why? Because it's positive myeloperoxidase in the cytoplasm associated with the translocation 1517 associated with hour rods. Okay? Now, we said the age on this one is kids. The age on AML, average age, 60 years. Okay? Now, I know it's kind of taking a little bit, but we're almost there, okay? For when it comes to CML, the chronic myeloid leukemia. Okay, what kind of cells would I see in this? Well, if I have a problem here, I'd probably have a ton of RBCs. Here, I'd have a ton of platelets. It depends where the problem is, okay? Now, just because you have a ton of something doesn't mean it's good, right? Because these guys aren't working correctly. So you have a ton of cells that just aren't very good. So the test question that I see a lot is this one right here, is that it's an increase in basophils. So if you have an increase in basophils, you automatically know that that's a chronic myeloid leukemia. So that's associated with CML. So the translocation on this one is at 922, the Philadelphia chromosome. You have the fever, you have the bleeding, you have the bone pain because you have a ton of this stuff in the bone marrow, but you have too much of it. But again, it doesn't work. You have the increase basophils, okay, that you're going to treat with imatinib, okay? Now this one also has that, that 922, the BCR, ABLA, or whatever, the tyrosine kinase is constantly turned on because of this. So what do you think imatinib does? It blocks tyrosine kinase activity. Okay, that's how it works. But for chronic myeloid, you got to know increased basophils, treat with imatinib, chromosome 9, the translocation 922, and that deals with the tyrosine kinase. Okay, and then of course the last one here, CLL, you're going to think an old person, so greater than 60 years of age. It's a B-cell leukemia. You know, it's associated with the smudge cell, and treatment is based on the staging, okay? And there was a question out there somewhere, you know, there's different stages. When you have a problem with this guy, you could have, you could have a increased white blood cells. You could have enlarged lymph. You could have spleen enlarged. You could have anemia. And you could have low platelets, okay? So this is all CLL. And so what they do, if you only have those two, it's no treatment. But if you have the bottom three, you're actually going to treat them with what? You're going to treat them, well, not that I expect you to know this is more of a step 2, step 3. This is the one where it's fludarabine with rituximab, okay? And when I say rituximab, you say CD20, okay? Now, trying to think if there's anything else that we need to know on this. This is the principle. Yes, this is a mess, but you should be able to go back and tell the story. And I'm not going to draw it all over again here, but I would say this. If you can get to the point to where you can just tell that story and group things into acute AML, ALL, CML, CLL, and then tell, you know, the details of each one of these, you'll be perfect for the exam. Now, back to this question. It says, you know, long story short, we're at the hour rods, so we know, okay? We know that we're going to be right up here, correct? We know that it's acute myelogenous leukemia. We're over here. So, does it make sense that neutrophils are decreased, right? Because the correct should be 60-30 percentage, right? Because they're not maturing to make neutrophils. They're not maturing to make the lymphocytes. But we have a ton of blast cells, right? So that confirms it's acute. It's AML. But I didn't put AML as an answer choice. So what is the correct answer? Is it associated with smudge cells? No, that's CLL. Is it the 922 translocation? No, that's CML, okay? Increased basophils? Well, that's CML again. Is it 1517 translocation? Might be. Is it 1221? And no, we said that one was ALL in the kids. So the correct answer is the 1517 translocation. A lot of work on that. But again, this video is more about having you to make sure you can tell the story and just tell a description of these guys. And then you should be okay, definitely for the STEP exam. Last question reads, 71-year-old man has increasing weakness, weight loss, generalized lymph node enlargement, hepatosplenomegaly. Lab findings reveal majority of cells being positive for CD19, CD5, CD20. Patient has mild hemolytic anemia. Which of the following is the most likely diagnosis? All right, so they're going for a leukemia. Now, and we talked about this, guys. You could almost do this, obviously, most of these questions, without even knowing all the details based on age. We know that ALL, kids, right? Kids, Downs. We know AML median is 60 years of age, okay? We know CML, I don't even know if I went over that one, the last one, 30 to 60. And we know CLL, greater than 60. So just based on age, you can pretty much hit this thing. Don't get too distracted on this because you're thinking, oh, wait a second, you know, didn't you tell us earlier that the pre-T in ALL had a CD5, right? Yes, I did, but it's not really pathognomonic for that. Or, you know, I went and dug this thing up about CLL, and you know, it talked about all these different types of markers and stuff. So, because I saw this question, there was a question very similar to this one that was on the NBME that's floating out there. So, anyways. We know this guy's got leukemia. Based on the age alone, you should be jumping all over that. Okay? Don't get bogged too much down in the weeds on this. And what do we say? If I see CD20, you think, oh, well, that can be treated with rituximab. Okay? All right? Anyways, go back, tell the story, and the rest of this kind of, RBC disorder, a lot of it's going to be based on, do you understand this? And if you can tell the story, I know you can do it. And then it's just a matter of filling in all the little gaps. So, hope it was helpful.